How about now? Can you hear me now? No?
Yep, I can hear you.
Okay. I don't know what happened. That was so strange. The one that was saved in the file wasn't the most updated.
That's weird.
So I went back through my PowerPoint, recent works. It was named the same exact thing, and it was there
Oh, that's weird.
with all the right slides and not those two blank ones. So,
Oh, that's weird.
do you know if I sent you one that had some green something slides, two slides on green survey?
Let me look.
Did you remember seeing those? I didn't go back and look what I sent you. I guess it's not really important as long as we got the right ones, but
Right.
yeah.
Let me see if I can look through mine though. Yep.
Nancy says on her calendar, this meeting is canceled. Not on mine. I'll resend it to her, but.
Luann, I think you had sent one out that was canceled and replaced it.
Oh.
So if they didn't take off the canceled one and put on the new one.
Then they wouldn't have got it.
Yeah. Good morning.
Hey.
This is Janet, by the way.
Hi, Janet. Yes, I'm actually able to recognize your voice now. Sometimes it takes me a while, but thanks for that information.
Yeah, no problem. I know it's happened to me with WebEx in the past.
Yeah, that's weird.
Hey, Luann, Katie's on the line.
Hey, Katie, how are you?
Good.
Yeah, Rebecca, the PowerPoint that's attached to the invite is not the corrected one, so we'll have to resend it and let people know that.
Okay.
That's strange. Well, whatever. Voodoo happens sometimes. I'm going to give it just a few more minutes. People are, oh, it's early yet too. Geez, I'm all kinds of crazy this morning. I'm going to give it just a few more minutes. I think people are still joining. Is that correct, Rebecca?
Yep, they are.
Okay.
Good morning, Luann. It's Nancy Gildersleeve.
Good morning, Nancy.
Okay, Luann, I'm not seeing any more people join right now.
Okay. So let's go ahead and get started. Rebecca, would you want to do roll call if you just call out people's names and at least let everyone say hey?
Yes, sure. One moment. Okay. So we have Abe,
Yes.
Brenda,
Hello.
Amanda Wisher,
Hello.
and Ian,
Hello.
Jessica Schwartzman,
Hi.
Katie Cook,
Good morning.
Kelly Owens,
Hi, good morning.
Sandy Birch, we do have a couple people on. It's showing as phone numbers, so if I didn't call your name, if you could just announce yourself.
Good morning, this is Janet.
Good morning. This is Lisa. Rebecca, it's Nancy.
Hi, this is Mark Adamick.
Hi, Mark. Okay.
Okay, thank you and welcome all. I hope everyone is doing well and being safe and healthy. As you can see, we have a pretty packed agenda with all that is going on. There's a lot to talk about, so I'm not going to hesitate. I'm going to let Katie take right over and give us the latest of telehealth.
Excellent. Hold on. Nope, this is the right slide deck. Excellent. I have so many presentations that I'm creating slide decks for, so I was tripped up for a second. So good morning, everyone. This is Katie from AHI, just kind of helping lead the telehealth charge here. But I just want to take a second and thank all of you guys who are on the front lines on the call, really doing great work. And there has been rapid deployment of telehealth services across the region over the last 2 months. And I've been really, really impressed with how quickly folks have taken to telehealth and adopted it. So part of my job is keeping a close eye on the regulatory and reimbursement updates. We have not seen any, thankfully, in about 2 weeks. So it has slowed down a little bit, but I wanted to go over some of the most recent CMS updates. So on April 30th, that was the real last change, major change that we saw, where CMS announced through a press release, and this slide deck will be sent out, so these links will be clickable. Through a press release, they updated their COVID-19 waiver summary document and created some provider-specific fact sheets, which included expansions in telehealth policy to address needs related to the public health emergency. Next slide, please. So during the public health emergency, some of the big changes that happened recently, that a lot of folks were really pushing for was that CMS is now allowing all healthcare professionals that are eligible to bill Medicare to be reimbursed for telehealth services. So this now includes physical therapists, occupational therapists, and speech language pathologists. So before this change, the eligible provider list was somewhat limited to doctors, mid-levels, and a few others. So that was a great change. CMS also announced they're waiving the requirement of video technology use for a certain set of services for the remainder of the public health emergency, and they are increasing the payment amount for telephone visits. So those are codes 99441 to 99443. And they're doing that in an effort to match payments for similar office and outpatient visits. So what was a reimbursement rate range of about $14 to $41 before has now been updated to between $46 and $110 based on the time spent with the patient. And these payments are retroactive to March 1st. A couple of other things on this grid here include the services that are allowable to be reimbursed through telehealth. Again, this is a clickable link once you get the slide deck, but it leads you to a spreadsheet on cms.gov that lists every code that is currently billable for telehealth. Additionally, there are currently, during the public health emergency, no geographic restrictions whatsoever. Patient and provider can be anywhere. Next slide, please. So Medicare coverage of federally qualified health center and rural health clinics. So as many of you probably know, prior to COVID-19, there were some restrictions on these facility types when it came to billing for Medicare telehealth services. They could not function as a distance site, meaning that FQHC and RHC providers could not bill telehealth services. However, with the CARES Act, that has changed. Medicare is now covering and reimbursing telehealth services provided by these facility types from January 27th through the duration of the public health emergency. I've linked some great guidance documents summarizing these changes that you'll be able to look at after. So some of the key flexibilities afforded include patients can be at any site, including their home. Practitioners can also be in their homes. And the reimbursement rate now for any telehealth service is a flat rate of $92.03. So that's for any telehealth service listed in the code list. That's the spreadsheet I was just mentioning previously. So for FQHCs, you have to report 3 HCPC or CPT codes, one being the PPS specific payment code, the second being the HCPC or CPT code that best describes the service with the 95 modifier, and a G2025 with modifier 95. So the billing rules are pretty specific around this, but again, reference the guidance that I've linked on this slide that goes into sort of the details around that. Beginning July 1st, federally qualified health centers and rural health clinics will only submit G2025 going forward, and rural health clinics will no longer use that CG modifier. So there's been a lot of new modifiers that have been put forth that are related to disaster codes, catastrophe related codes and modifiers. So I'm not going to get too into the details with that, but you know, I am here to help answer those questions. Next slide, please. A few other updates. CMS added hospitals to the list of locations that qualify for an originating site facility fee when a hospital-based provider issues an encounter to a Medicare patient currently under outpatient care, including in their home. So an example of that kind of service includes counseling, education, and therapy, and they did release a fact sheet on that. So during the public health emergency, if the patient's home or a hospital temporary expansion site is considered to be a provider-based department of the hospital, and the beneficiary is registered as an outpatient of the hospital for purposes of receiving telehealth services, the hospital can bill under the physician fee schedule for the originating site facility fee associated. So that previously was not allowed. Next slide, please. Additionally, I'm not going to go too into the details with this because it is hospital-based, but CMS did release an FAQ document addressing issues for hospitals and critical access hospitals regarding the Emergency Medical Treatment and Active Labor Act. So some of those questions that I highlighted here, there's more than just these four, but can emergency physicians and other healthcare practitioners conduct medical screening exams via telehealth under this act? So the answer is yes. You can do a medical screening exam performed solely via telehealth if clinically appropriate. Another question, can out-of-state emergency physicians provide telehealth to beneficiaries in a different state? So there's kind of a two-way answer to that. So for Medicare and Medicaid at a federal level, CMS waived the licensure requirement, provided that the physician has a valid license in another state. In order for this federal waiver to be effective, the state also would have to waive its licensure requirements. So the Federation of State Medical Boards did create a wonderful document that has outlined basically all 50 states and what their individual states' stance is right now on waiving any sort of licensure restrictions. So for New York, as far as I'm understanding it, New York patients can be seen by out-of-state providers so long as that out-of-state provider has a valid license to practice medicine in New York State. In terms of a New York State provider offering their services to patients in other states, you would have to look at the state that the patient is in and refer to that state's particular guidance when it comes to licensure. Next slide, please. Additional updates as of April 30th and May 1st, opioid treatment programs can now furnish periodic assessments via telephone. This is only for the public health emergency, but provided all other applicable requirements are met and there is no possibility that the beneficiary can access audiovisual technology, telephone calls are now considered appropriate. Next slide, please. So additionally, CMS is allowing for the E&M level selection for office or outpatient services furnished via telehealth can now be based on medical decision-making or time for the duration of the public health emergency. There was some confusion in the physician community around this because the public use file from Medicare did not always align with the typical times included in the office or outpatient E&M code descriptors. So CMS resolved this confusion last month by revising their policy to clarify that the times listed in the CPT code descriptor should be used. Next slide, please. And then lastly, major changes include loosened remote patient monitoring billing requirements. So historically, you could not bill for fewer than 16 days during a 30-day period, but acknowledging that many patients with COVID do not need to be monitored for a full 16 days, CMS is saying for the duration of the public health emergency that monitoring services can be reported for periods of time that are fewer than 16 of 30 days, but no less than 2 days, only if the patient has a suspected or confirmed diagnosis of COVID-19. So it can't just be for any patient that you're monitoring with a chronic condition. They have to have a COVID-19 suspected or confirmed diagnosis. Next slide, please. A few other policies I just wanted to throw on here. So providers do not need to put their home address on claims if they conducted a telehealth visit while at home. Of course, the Office of Inspector General is providing healthcare practitioners the flexibility to reduce or waive out-of-pocket costs and copays. Prior existing relationships do not need to be established for telehealth visits. And as you can see on here, CMS is waiving a number of requirements specifically for nursing homes. As an example, they're waiving the requirement that physicians and practitioners perform an in-person visit for nursing home residents. They are allowing telehealth. Hospice as well. They are waiving the requirement that face-to-face encounter has to be done to determine continued eligibility for hospice care. This can now be done via telehealth. The previous frequency limitations on inpatient care and SNF visits has been waived. And supervision, physician supervision can now be done using live video. Next slide, please. Now I want to talk about DOH and New York State Medicaid specifically. So on May 5th, the Office of Health Insurance Programs, specifically Greg Allen and some folks on his team, did a great webinar outlining a lot of the changes that DOH has made. And I applaud DOH for the many changes that they are making and how specific and clear they are attempting to make their guidance. It has been very helpful. So, as many of you have probably seen, DOH created this great 6-lane billing grid. So lanes 1 through 4 are up here on the slide. Anything that's in bold is a new addition. So a few examples include the addition of the place of service code and modifier columns. Those were not previously on there. So a couple of changes include simple things like change the setting from office to practitioner's office. In lane 1, a big change was nurses can bill for telephonic services using code 99211 with a GQ modifier. The GQ modifier was always the store and forward modifier previously, but they are asking that the practices bill with this modifier for tracking purposes. They want to see how many telephonic services are being provided, and that's a way for them to capture that. In lane 3, there's an addition of 2 rate codes that clinics should report, including the CPT code for the service provided. That previously wasn't on there, so 99201 to 99215 was not previously on the old billing grid, so now that has been added and no modifiers required. Lane 4, the telephonic service column now includes social workers and psychologists, and RAP payments are available for the listed rate codes. No modifier is required. Next slide, please. And this just shows lanes 5 and 6. So in lane 5, dentists were added as an applicable provider. And in lane 6, school supportive was added as a setting. Next slide, please. A few notes from that webinar. So high level points here. Obviously, New York State Medicaid is reimbursing telephonic services if it is appropriate for the member to receive them via telephone. From what I'm hearing and seeing and what's being reported to us, that telephonic services have been used widely across our region, which is great to hear. Obviously, they established new payment pathways. Greg Allen did state, anything related to OPWDD, OMH, or OASAS needs to be referred to those specific agencies. During the state of emergency, there are no limits on an originating site. It's anywhere the member is located, including their home. And the distance site is anywhere the provider is located within the 50 United States or United States territories, and this includes FQHCs and provider homes. Next slide, please. We did talk quite a bit about Medicaid managed care. So Medicaid managed care plans do need to follow the fee-for-service telehealth billing policy, including telehealth and telephonic services, but they can establish separate detailed billing guidance from fee-for-service. These plans do need to establish payment pathways for telephonic encounters that can mirror the 6-lane billing grid I described previously, but they are not required to mirror it. They can provide their own pathways. I haven't specifically seen any plans release information related to this yet. Absent negotiated rates for telehealth and telephonic services, these plans must reimburse network providers at the same rate that they would be reimbursed for face-to-face encounters. So if that's not happening in your practice, that could be concerning because the state has put forth that it has to be a one-to-one reimbursement. Next slide, please. So sort of the $1 million question that I think a lot of folks are asking, I'm being asked, I'm sure DOH is being asked. He made a point that, we do not know what the future will look like in terms of what regulatory flexibilities will remain or not. All of the guidance, both at a state and federal level, is very clear in stating that it's for the duration of the public health emergency. So if and when that public health emergency ends, what will stay? So DOH is continuing to monitor and update policy guidance. Greg Allen did state that they expect that some face-to-face visits in the future will migrate to telehealth as appropriate. So I think the best thing is we just wait and continue doing the work that you're doing with these flexibilities in place and in mind, and we'll just have to wait and see what may or may not remain. There is an email address on the bottom here that folks can send questions to. They have been taking like a week or two to respond, but I imagine that's just because of the sheer volume of assistance that they've been getting asked. Next slide, please. So I just wanted to touch on the Federal Communication Commission announced back in early April the COVID-19 telehealth program. So this was $200 million in funding as a part of the CARES Act to help providers in delivering connected care to patients in their homes or mobile locations. Next slide, please. As far as I know, the 6th round of awardees was announced last week. I think it's actually further than May 6th, but there are 82 health systems across the United States that have been awarded just over $33 million so far. So there's still quite a bit of money up for grabs. So a few New York State health systems that have received funding include BHSN, which is in our region. That was really exciting to see. And then a few bigger health systems downstate, Mount Sinai in New York City, NYU Langone Health, Institute for Family Health is an FQHC downstate, White Plains Hospital Medical Center. So you have to be a nonprofit eligible healthcare provider. So I imagine that some of you, if not many of you, have looked at this funding. Hopefully you're considering applying because it seems like they're approving applications on a rolling basis, and there are still a significant amount of funds up for grabs. So that wraps up my presentation today, and I'd love to take anybody's questions they have. Just sharing thoughts. How are things going with telehealth? Are patients taking to it? Are they enjoying it? Barriers you're running into? We'd love to hear it all.
Katie, this is Abe with Adirondack Pediatrics. Last week, Excelis told us, and they're the only ones so far, that as of June 30th, they're considering right now everything will need to go back to normal, that they will only cover telemedicine as it was prior to the public health emergency.
Interesting. Why June 30th?
I don't know, but that's the date in the letter that was dated May 13th that was sent to us. They said they reserve the right. They may push it back, but as of right now, we're told that we need to go back to just what their previous policy was that they put out last August.
Abe, this is Luann Villani. Would you be willing to share that letter with us if you would want to email it to me?
Yeah.
We are trying to work with the state and the payers as well to, kind of push some of these ideas that they have of turning back everything right away. So I would be interested in seeing that, and myself, and I think Nancy Gildersleeve's on the line as well. We can take this forward to our leadership and see if we can't get some state people to take a look at that. And we do have some relationships
Hi,
with.
Luann, it's Brenda.
Hey, Brenda.
Hi.
Oh, good.
Certainly we have calls with the payers, and we certainly will bring that up.
Okay.
I think Excelis right now, I think they said, goes back June 30th, but I think that really leaves a lot thinking that things starting to head back in a normal course. and trying to, in all honesty, I think it's trying to start preparing people that, at what point. We don't really know. I think they've left that open, but certainly we have calls with them on a very regular basis. So I will certainly, we'll bring that up on our next call with them, and certainly I can let people know.
Okay, that would be great. And we as well will raise those kinds of questions any which way we can, folks. We are, just a little tidbit, we are looking at all of these regulation waivers that came out and getting a list together to go to the state in general and say, these are the ones we really can't roll back anytime soon. And even recommending some of them become, permanent regulation changes. But obviously that's going to take a little bit longer than June 30th.
Yeah, I mean, because we started, we never closed, we never reduced hours, never laid off staff. We've stayed full running the whole time, but we transitioned to the majority of telemedicine for most things, including child well visits over age 2. But we started earlier this month, started phasing in, bringing patients in for their well visits back into the office, and starting June 1st, all well visits we'll be doing, but we're still offering, if the parent isn't comfortable yet coming to the office, to do a well visit via telemedicine. But with Excelis, they're saying that after June 30th, that they won't pay for pediatric well visits that way, and as well as all well visits that we did for Excelis, we need to bring them back in within 90 days of their original visit and do a second well visit, but bill it out with a $0 charge.
Oh, geez.
That's all in the letter. Thankfully, we don't have a lot of Excelis. It's very small for us. Blue Shield and Northeastern is our bigger Blue Shield in this area, and talking to them, that's not a concern for them. They're like, if you need to bring them back in, if there's something you're concerned about, but otherwise, because of everything going on, they feel it's more important to get the other aspects of a well visit completed and keep patients on schedule and do the shots in the parking lot and everything. So it was just interesting. I didn't know if anybody had heard, if anybody other than Excelis was starting to try to end this sooner than like what the rest of the world is saying. So.
No, this is Katie. This is the first I've heard of something like that. I get the wanting to be proactive, but it does feel a little soon to make that call.
Brenda, have you heard from any other payers of such?
No, not yet, but in accordance, I think, during this time when we're looking at how they have flexed everything, when we go back and when you're looking, and certainly I'm here advocating that we should extend it if that's where, where things are heading. I think, long term, where is this headed? And the HEDIS metric, as we know, that HEDIS is really going to have to retake a look at a lot of these measures, but certainly any of our well child visits and any of those are certainly, when you're looking at the HEDIS specs, telehealth is not an acceptable format, which we know that that's stuff that we have to work on going forward, especially with the fact that it has been very, people have been very receptive to that. Certainly, like I said, we will, we have a very good working relationship with Excelis, so certainly can ask them on our calls with them. So, and
Great.
we'll get back to everybody.
Thanks, Brenda. Okay, Katie, or anybody else for that matter with some questions for Katie.
Hey, sometimes no news is good news. But all of you know how to reach myself or Nancy Del Mastro. We're here for you. And if we don't know the answer, we will point you in the right direction or include you on communication to find the right answer. So appreciate the opportunity to speak and thank you.
Great, thank you. Okay, a couple NCQA updates. Some of this I think is pretty common knowledge, but just wanted to reinforce. Their COVID page is constantly being updated as well. So as they're making changes, it is there. And I just gave the link directly to that COVID page. While they still say on the page that there is no blanketed extensions, we have seen and heard other venues that have said pretty much anybody that was due between March and September would be given extensions through December of this year, which means you'd start your submission December 1st. But we have heard as well that when you still have to put in the request to have the extension. And we are hearing that different partners are getting different time frames. Yes, December seems to be the most common at this point in time, but others have, been working to get different extensions based on their needs.
My extension is due in November, and they sent me an email a couple weeks ago automatically telling me they had automatically extended my deadline till December.
Oh.
And I didn't submit for it because we were on track to be able to submit on time anyways.
Great.
Luann, this is Jessica. I've had a couple of practices indicate that they also received a letter. So I did reach out to NCQA, and I was able to hear back from them yesterday. And although for the national programs, UCMH, they are requiring that practices reach out to get an extension, they recently made the determination for the New York State program that anybody with a submission date from March through September, that will be automatically extended to December 1st for a submission date. So that your anniversary, if you were to go on the NCQA report card webpage to find out your anniversary date, it will be listed as December 31st with a submission date at the latest of December 1st. So they have done this for New York State. They did not communicate this to anybody except for the direct primary contact in QPAS. So if you have a primary contact in your QPAS account who is somebody who's left the organization or they're not in that role anymore, try to make sure that that's updated because they did not send this out to CCEs or TAs or any other organizations. As far as I'm aware, they only sent it to the primary contact. But I did have that conversation. So if you had a reporting date that was March through September of this year, you now have until December 1st to submit your submission.
Thank you, Jessica. Just a couple other points. There definitely is, if you do go forward with submitting, there's definitely some increased flexibility during the virtual reviews. The other reminder is you can show evidence of any processes in the past year. As we continue to move forward, that still becomes a challenge. But again, working with the reviewers, I think we've seen some very flexible resolve of some of the criteria that has to be met. And then just a question in general, have you seen some criteria that have been impacted by your practices? Again, making notes of that yourself. I know we sent everybody the spreadsheet tools, but to kind of make those notes that say, these are the timeframes in which we couldn't do proactive reminders or, risk stratification, although that seems to be still pretty much on track with many organizations, but the comprehensive health assessments, if you weren't able to get all of those done. So whatever the criteria that you're struggling with, it would be worth your energies to kind of note it on those spreadsheets so that as we do get closer, or as you do get closer to having to submit, you'll have that information as to when you stopped or when you had to decrease your ability to do those types of outreaches. Next slide, please. Just a reminder as well, weekly, they are doing a primary care survey. And the site is, you should be able to link through it here. It's done every Friday. They put out a new one or request one. So you will see one tomorrow. Just a real quick latest results information from the week of May 5th through the 11th. Interesting, again, 50% of the clinicians are reporting that they haven't received any payments in the last 4 weeks. reporting billing was denied. Again, I think everybody has seen some struggles. And I think the more information you can provide, the more information they're able to collect and present forward to various groups and organizations and regulatory bodies to, bring it to their attention that people are continuing to struggle with some of these issues. Can you advance the slide, please? As well, Primary Care Collaborative on their website, and here's the link as well, also shares with you information from the survey as it's getting collected and updated, and they do denote which week they're talking about. So there is some also suggestions that they give about what people can do or can't do, or they're accordingly putting out various WebExes or white papers to answer some of these challenges. So it's another great resource. Anybody with any questions about NCQA criteria, anything along those lines? Okay. So then we thought we would see if you couldn't have some discussions about the high-risk patients and the risk stratifications. Specifically, I know many of you are still running your risk stratification reports based on your previous risk stratification criteria. Some have reported that they've modified their criteria a little bit. Is anyone having challenges with working on this? I know Brenda can speak to what they have been doing at the ACO for reports, as well as our own AHI Health Home, which again covers the entire region, has been pulling out risk stratification on patient populations that might not be connected, that potentially could or should be connected, and doing some outreach there as well. Brenda, do you want to talk about the ACO reports, and then we can see if anyone has specific questions or needs?
Sure. So those of you who did receive the report, it was based on the 4 payers that we have in Health Catalyst, and was looking at their risk, a composite score of risk and cost. I think it did a pretty good overlook, the problem being, which, some of the feedback that we got back, which was great, helps us moving forward. And I know right now we're in the process. Some of our lists were pretty long for practices, and I guess when you live in the north, practices are not as big as some of the larger practices in the southern region of the ACO. So what we've done is looking at the top 5% instead of the 10, but also there was requests about looking at medications, because I know that many of you, received notifications from the different payers that somebody didn't refill, or, the med adherence piece. So we're looking at how we can pull that information, that data in, and we're waiting for the next data refresh before we push out. But we're looking to include another request was bringing in the number of ER visits during the course of the year, which would help to identify to them, the cost piece is there, but you don't really know what drove that cost. So being able to, bring in the ER visits and things of that nature. So, it's all great feedback that people were sending. So we're working on that next, the next report once we have the updated info in Catalyst.
How is everyone doing? Do people need assistance? Do you have questions? Any specific information you'd like to share? Okay.
Hi, it's Luann. I'm just going to jump in again for a second. I think, everybody that's on the phone that, some of you are probably new to the ACO, and we are in the process of getting data for you as well. I mean, if you identify areas or things that you would specifically like to look at, in order for us to create reports that are actionable for you, you know, certainly the information we took back to the team was from, you know, care coordinators that are providing service, doing outreach, and so that they could really focus the specific group within their organization that provides, whether it's transitions of care or if it's chronic disease management or if it's behavioral health. So, I mean, if you're able to get that information to us, we are currently looking at working with one of our para organizations to do some deep dives into very specific cohorts, patient cohorts, to see if we can drive, you know, certain actionable items on, you know, from that standpoint. So if people have any information or ideas, please forward that to me.
That's a great call out. The other thing too is working with Hixney. They are as well trying to, they have been deploying some information about ED high utilizers. So they're looking at those that were considered ED high utilizers over the past year, and then trying to identify those that have not sought out any assistance at all in the past whatever time frame, and it varies when they pull the reports. They are not quite ready for public prime time, but as soon as they are, we will let people know, and they can push it out to you as well for your patient populations. So yet again, another take on a risk stratification that might bring attention to some of your patients that are not getting care that you believe should be getting care. And if you have any questions, like Brenda said, you can certainly reach out to her and or any one of us at AHI. We too are working psyches and the Medicaid databases and the Hixney data to try to pull out information that people might need. Okay, next up, Brenda was going to give us an update on payers and challenges people might be having. So go for it, Brenda.
Thanks. Currently, you know, the ACO, we do have a quality payer meeting that's coming up next week. After our governance meeting, you know, with the payers, we really know that this year, you know, we do have goals that are set for the 2020, and certainly knowing the challenges that are around COVID and what that's brought to us, what we, you know, looking at the goals and what's really going to be happening. You know, certainly if you watch, you know, the HEDIS site and looking at stuff that they're, you know, talking about, everything is in a holding pattern until, you know, somebody makes a movement here. So I think we're all, you know, waiting to see what direction. We will have New York State QAR will be presenting to the payer group next week, so that we're actually able to kind of hear what direction New York State is taking, or kind of what they're, you know, what they're hearing. And certainly going from there, I think one of the things that we will be working on is how can we look at the measures that we are responsible for, and how do we, you know, is it just going to be a pass this year? I don't know. You know, those are the types of things, but also looking at different ways of how we can meet the measure requirements. And you know, certainly it's also another opportunity for us to also bring up that Excelis question and really hear from the payers what they're doing. That was me, and I'm fine. So if you heard that, all is good. Sorry. So I think, you know, there's just a lot of questions. I mean, nobody has the answers. And Abe, you know, certainly we will take that back to Excelis. We certainly, you know, want to make sure that, you know, I assume, and I shouldn't assume, but, you know, I think that was just a matter of putting a time frame that they go back to revisit those things to see where the state is. But I mean, if anybody has any ideas, I mean, we are working with one of the payers around colorectal cancer screening, and I know that there are several people on the call that are working this initiative from their, you know, with their practice with the payer organization. I think, you know, the collaboration is there for several of the different payers. They're willing to see what they can do, and, you know, how can they assist practices to, you know, help some of the gap closures. You know, even when you think of, you know, taking a blood pressure, somebody that has hypertension and they're not coming in, having that audio visual to watch the person take their blood pressure and get a visual read of the readout, payers are going, several payers are going to accept that to meet the measure. So there's going to be some leniency, and certainly I think, on the HEDIS website, certainly there's, certainly questions that are going to, every day. So if you want to see, some of the things that are happening, you can go there, but we certainly will give feedback. And if you have any ideas or, any of the challenges with the payers, please make sure, reach out to me and, let me know and we can bring that up.
Okay. A couple other just reminders on additional resources. Obviously, the AHI website has a COVID section, if you will, that will link you to any of the waivers and regulatory changes. The telehealth webpage, there's a direct link to all the information telehealth. And we also provide links to the state sites as well, DOH, OMH, OSS, OPWDD. We have Monday, Wednesday, Friday still coming out, the COVID newsletter that gives you latest and greatest updates and any communication from any of our partners of things that are going on or resources, programs. And then also the ACO newsletter comes out, and they too have been providing information around COVID and all things ACO. So that's been a huge help for everyone. I have nothing else. I don't know, Brenda, if you have anything else?
No, I don't have anything else, Luann.
Does anybody have any questions or concerns they want to raise? Topics they'd like to hear about more?
It's not really a question, but it's more, I don't know if anybody else has gotten calls yet, but as everybody knows, you can't use, the payers can't use HCSCS data for completing or showing that a HEDIS measure has been met. But right now, NCQA is actually conducting research to see they're having the payers reach out and look for sample data from individual payers' databases to compare to HCSCS, so that may be able to change, so that like next year they may be able to just look at HCSCS and be able to say a measure's been satisfied.
Right.
It was something that that's kind of been since
Yep.
last summer. It was brought up. I got a call yesterday from CDPHP. They're looking for data.
Yeah, so the other thing that's happening along those lines, that's a great point, is HCSCS is working with NCQA and trying to become recognized as a source to be able to provide quality metrics and meet those HEDIS needs. And they're going through that, I don't know if it's a certification, recognition, whatever they want to call it, but they're going through that right now. So we are hoping that that's going to get granted, and then we could encourage all people to be able to use that. As well as, I know not just HCSCS, but all HIEs are looking at how they can provide quality metrics and getting those to payers and or NCQA, CMS, wherever they may need to be sending their metrics. And that is a global work effort by NICE, which is the overarching of the Shiny and everyone else, that they're really trying to work on that and promote that the HIEs be able to provide that information, because they do have such rich data. So that's a great,
and they need our data as providers to be able to verify that the HCSCS data is in fact accurate. So I guess what I'm saying is, if people get calls for that, please offer, because they only need one they're only going to ask on one patient for one data service, so it's not a lot of work even right now with everything that's going on.
I would agree. That's a great point. And the other thing too is looking at HCSCS, as we continue to work with them, looking at how providers, the EHRs, and working with the EHRs to make sure they're submitting the information and data in such a way that it can be easily pulled out and provided to other resources, payers, CMS, et cetera. So that work is going on. It's, as you can imagine, a slow process sometimes with getting the EHRs to the table, but they do have some of the larger EHRs right now that they are working with to try to make that happen. Anyone else with any updates or helpful information? That was great. Thank you. Okay. I hope everyone remains safe and well. Have a great day. It's good to see the sunshine. I'm sure you're all agreeing to that one. And have a safe holiday weekend, folks.
Thank you.
Bye.
Bye.
You too. Thank you.
Bye.
Bye-bye.
Guys.